Well, thank you very much, Sam. I appreciate the introduction. And congratulations to Dr. Ramchandani for putting together, without question, the best hands-on conference that we have. And congratulations for the partnership with ISMICS. I think that's a big step ahead. What I'm going to talk about today, and I think you got a sort of a glimpse at this afternoon, we're going to have a lot of time where we're going to go over videos, we'll have cadavers, we'll have models, we'll have all kinds of ways of demonstrating how minimally invasive coronary bypass can be done. So I'm not going to do a lot of slides on the technical side, but I'll touch on it just so everybody has a little idea about what exactly I do. I have a couple of slides on why I think it's important that we all learn minimally invasive coronary bypass, and some slides on starting a program, which I think is probably one of the biggest obstacles, is getting the program up and running safely and with a robust amount of volume. And then I'll go over some of the results that we've had between myself and Dr. Mark Rowell from the University of Ottawa, Canada. Okay, so just a little overview. I have this slide. Again, I'm not going to get into a lot of the technical slides because we're going to do that this afternoon, but just so everybody understands the basic layout, what I do is a minimally invasive bypass surgery through 3 small holes, one in the 4th interspace that's about 7 or 8 centimeters long, a 6th interspace portal, and a subxiphoid portal. And that's the basic layout of the surgical approach. Am I making that work, or is it not changing? Okay, so the MiCS CABG. Okay, it's not working. Okay, here we go. I hit it about 5 seconds ago, so okay. We'll see. All right, so anyway, one of the points about the MiCS CABG is fairly versatile. When I say versatile, what's going on here? All right. Oh boy. All right, when I say, thank you. When I say it's versatile, you got another one for me? Thank you. Thank you very much. When I say versatile, I mean that it can be done in a lot of different ways. For instance, it can be done in conjunction with a drug-eluting stent, or it could be a complete revascularization. It depends on the scenario and the coronary anatomy. It has exactly the same strategy for grafting as it does through sternotomy. For instance, the internal mammary artery is isolated to the LAD. We create aortic proximals in the same location that you would do it through a sternal approach. In addition to that, you have the ability to do this either by on-pump or off-pump technique, depending on your approach for that particular patient. One of the beauties of this operation is you use regular instruments. And as you saw on the slide before, I create that opening in the 4th interspace. It's about 7 or 8 centimeters long, and it happens to be right over the distal part of the heart. And what that does is it enables you to move the heart around into that incision so that you can get to every distal and use your regular needle holders, your regular pot scissors, whatever you typically do to sew your anastomoses. You're going to use those things. And I think that's part of the rationale behind it. In most typical endoscopic surgeries, you're on the end of long instruments. And those instruments will get you to the target, just like a gallbladder, for instance. Whereas in this surgery, I think it's too delicate to be handling a 7.0 on the end of a long instrument. Of course, you're going to hear a little bit about how the robot deals with that, but for your average person holding a long instrument, wielding a 7.0, it's not really feasible. So you want to be able to get the target into the incision, use your regular instruments to create the anastomoses. In addition to that, it's a direct vision operation. What I mean by that is you can see on this particular slide, I'm wearing a regular set of loops. I'm looking into the incision using specialized instruments and retractors. And you can also see everybody else is trying to look in. It's kind of hard to get so many heads into one little incision. But the reality is that all surgeons are very comfortable with direct vision approaches. You don't need any TV screens. You don't need anything special to get this program up and running. So now a little bit about why I think it's important that we all learn this. And the whole essence of my next few slides has to do with the comment that people really just don't want sternotomies anymore. And that's basically the end word, but I'll go through this for you. Because of its all-comers design, Syntax is undoubtedly the most definitive and compelling of all the CABG trials, CABG versus PCR trials. The investigators estimate that about 2/3 of patients with complex coronary artery disease are best treated with CABG. And Professor Taggart was here, I think, 3 or 4 years ago, and he gave a beautiful dissertation on coronary bypass versus PCI. It's clear to most people that this is a very accurate statement. The problem is that many or most patients are still being treated with drug-eluting stents, despite the fact the literature is clearly going in the direction of bypass surgery. So this is an article from the last syntax update, and I'll just read the quote. Despite the joint assessment of patients by the heart team, more than 4 times as many CABG patients withdrew consent to participate in the study compared with PCI patients, 50 to 11. Later on in that same article, Dr. Moore says probably because patients were concerned about the greater invasiveness of CABG. So basically, summary here is people were dropping out of the CABG arm because they were getting sternotomies. So we have the literature going in the direction of coronary bypass. We have a lot of evidence that patients are drifting away from coronary bypass because of the sternotomy. And so I think we need to, as a group, figure out a way of creating a minimally invasive approach for coronary bypasses that makes sense for the patients and our population we're taking care of. Now, here's a little bit of an interesting twist on things. When we do an article, we always look at endpoints. It's a big thing we talk about before we start the study. We want to design something that has endpoints in mind. The endpoints for us are typically MACE. Did the patient die? Did the patient have a stroke? Is the patient back in the cath lab? These are all things that we think about when we're creating a study. But the reality, what do patients think about? What are they thinking about when they're having an operation? They're not thinking about, gee, am I going to have a stroke? They don't even think about, am I going to die? What they're really thinking about, am I going to have a lot of pain here? When am I getting back to work? Those are 2 of the top things on their list. So I think we need to adjust the way we look at our literature and design our studies so we can take into consideration a little bit more about the patients and what they really want. Because if you look at the literature, patients are opting out of coronary bypass and getting 5 and 6 stents simply to avoid getting a sternotomy. And this caption says it all. This patient would have needed 4 or 5 stents to get that complex LAD diag done. As a matter of fact, this patient did have 4 or 5 stents to get that complex LAD diag done. But in reality, if we had a minimally invasive approach, that patient would not have been subjected to a suboptimal operation. And this quote pretty much says it all about where we're heading with that. Now we'll go over a couple of tips to get things started. I think it's very important in order for you to get a mixed program for coronaries up and running that you have a sort of a plan ahead of time. One of the plans is to get the cardiologists involved. I mean, they are very integral in this whole process, and I think one of the ways you can get them and keep them involved is to have as many of your cases have a joint approach, sort of a hybrid approach. I think it's an excellent way of approaching this, and I'll just give you my own little twist on this. Everybody knows that a vein graft to the right coronary has about anywhere between a 5 and 10% chance of failing. If it's a simple lesion, you put a stent in that artery, that's got a less than 1% chance of failing. So on a lot of cases, you might want to think a little bit about how you want to approach these and get the cardiologists involved, because I think this is a kind of place where we can work together with them. And if they buy into this kind of thing, it's going to take off. You want to monitor your results, and you want to report your results locally to your own group. Let everybody know what you're up to, what kind of complications you're seeing, and what kind of benefits you're seeing for your patients. I did a lot of utilizing my own cases in the beginning. If I got referred a patient who had triple vessel or left main, I would try and do as much of that case minimally invasive so I can get through the learning curve and use the cardiologist as an adjunct to try and help me with some of the vessels I just couldn't get to. And I always recommend touting the benefits of the internal mammary artery. I have not bumped into a cardiologist yet that has not said that they agree that putting a mammary onto the LAD is one of the most beneficial things you could do to a patient with coronary disease. And I think that still stands, and I think that'll probably always stand. So I think that's something we really need to push hard to our cardiologists to get us up and off the ground. Okay. Okay. Before you start doing cases, I think it's also very important to pile up cases. In other words, have 3 or 4 or 5 cases ready to go and try and get as many simple ones as you can. Now, this is challenging with coronaries because coronaries typically are time sensitive. Whereas a mitral valve you've been following for 3 or 4 years, or an aortic stenosis following for a couple of years, you can schedule those in a time that is convenient for your learning process. So coronaries is a little bit difficult, but I think it is important. Visit a center that's actively running and doing a lot of mixed cases, and bring everybody. I love the teams that come with their nurses, their anesthesiologists, their PAs, because those are the teams that actually end up starting a mixed program and having a successful one. I do like proctoring. I think it's important because there are so many steps involved in these procedures, and you'll see in the laboratory this afternoon how many steps there actually are, that you can't remember them all. So having a proctor there who's done a couple hundred of them makes a lot of difference. And I've had some cases where surgeons have tried to learn the operation, gone back to their hospital, and struggled, and when I went to proctor, realized that they were skipping some key steps that they just completely forgot about. Of course, a dry run, making sure the equipment is ready, is important. Patient selection is really key as well. This is a slide I stole from one of the Medtronic reps, and I think it says it all. I don't have to tell you that this is not a case you want to start off with. Obesity is probably one of the major contraindications to doing this case. As you can imagine, again, I said the idea is to bring the target to the opening so that you could use your regular instruments. If you got 3 inches of fat between the skin and your target in addition to the normal depth, you're going to struggle. You're going to have a tough time. Peripheral vascular disease is another relative contraindication because of the fact that my bailout strategy right now is not a sternotomy, but is cannulating the groin and getting on the pump. And if you have significant disease in the peripheral vessels, that could be a challenge. And anybody who has diffuse coronary disease who needs 6, 7 bypasses, those patients they're getting a sternotomy, and that's just the reality of life. This is just a couple of cases where I would definitely do a sternotomy. You have to do, in this case, 3 anterior vessels, distal LAD. You got to do a mid LAD. You got to do a diag. There's a lot of work to be done in this guy. So that's a case I would definitely do a sternotomy on. As is this case, this guy has got such bad disease in the right. He needs a graft on the PDA and one of these PLs just to make a complete picture on that one. In contrast, however, this is a case that might be a good case for a mixed case. Okay, well, there it goes again. First of all, the circumflex is pretty much in the right realm where you'll be able to access it pretty quickly and easily. The LAD is pretty devoid of disease distally, and there's a lot of spots where you can plug into. So this would be a case that would be very amenable to a mixed CABG. And the right coronary, by the way, is without problems, so that makes a big difference. This is another case that has a big wraparound LAD that you'll see in the next time it starts zipping around here. And that LAD should be no problem bypassing that one, and a nice big circumflex. So another good case for a mixed CABG. Keep in mind that that's the kind of vessel I would shunt because of the large territory that LAD supplies. Okay. This is another case where you could, this is a good case to demonstrate. I would do this case as a mixed case, even though you see over here the right filling in late, this PDA will end up being non-bypassable. So the left circulation is amenable to mixed CABG, but the right circulation is not, but it's not a big deal because this patient actually has an inferior wall infarct with Q waves in 2, 3, and F, and a non-functional inferior wall on the angiogram. Just moving on to a little bit of results, because I want to stay on time. I don't want to get impede into other people's time. But Dr. Ruel and myself have written a lot of articles about multi-vessel mixed CABG, and this is just one of them, and this is the one that we looked at our patency on the vessels, and I'll just read this caption and give you a little summary of this particular publication in JTCVS. The median length of stay was 4 days, and all patients were followed at 6 months. We had no MACE, no mortalities, no adverse cardiac vascular events. And the 6-month CT angiogram showed a patency rate of 92% for all the grafts, and we had 100% patency for the left internal mammary artery grafts. And I think the sum substance of this article is that, yes, this is a very safe operation, and yes, we can get very acceptable graft patency rates. Some of the characteristics of our first 1,000 patients is very typical of your standard cohort of coronary disease. There's nothing really to point out on this slide other than the fact that we get referred a lot of 1 and 2 vessel disease cases, and we do get referred those cases because of the fact that we do minimally invasive, so that skews the results a little bit. And On this case, you'll see that most of our, on this slide, you'll see that most of our cases are urgent cases. There are some, many electives and very rare emergency cases. We don't typically do emergency cases through this technique. This is just a slide to show you that basically every vessel on the heart has been bypassed, and more than once. Every conduit has been used through this technique. This is just a slide to demonstrate the fact that over the years we have increased the number of coronary bypass, amount of time we use the bypass pump. We're up to about 12 or 13% at this point. In the beginning we did much less. But if you'll notice on the other side, we're going down in the number of conversions to sternotomy. In the beginning, my bailout strategy, and so was Dr. Ruel's bailout strategy, was to just do a sternotomy if we ran into any trouble. Now our bailout strategy is get on the pump through femoral cannulation or peripheral cannulation, whatever that means. This is another results slide. I'll point out again, the only really significant thing on this is the one right here, and it's a deep wound infection. And I stumble every now and again because I say deep sternal wound infection, but there is no sternal incision, so you can't have a deep sternal wound. But there was, out of the 1,000 cases, only one deep wound infection. That wound infection was healed by a secondary intent. It just needed some dressing changes and healed in a couple of weeks on its own. No plastic surgery consultations, none of that. So this really changed the way we look at who we do MiCS CABGs on. Just for an instance, I don't do MiCS CABG on people on steroids. I don't do a sternotomy, rather, on people on steroids at this point. I prefer to figure out a strategy where I can get those done through a minimally invasive approach. This is a slide that I like to show that demonstrates what I said earlier on, is that this mimics the way we do it through sternotomy. This is a gentleman who had 4-vessel bypass through a MiCS CABG. You can see the internal mammary artery going down to the LED, which is very similar to the way it would course through a sternotomy. You could see on the left side you have 2 vessels, one going to a circumflex and the other one going to a diagonal. Again, they're attached to the aorta, a very similar location they would be if it was a sternal case, and they course right over the pulmonary artery like they would in a sternal case. This is the PDA going around to the right side of the heart and coursing over the right atrium just exactly the same way you would see it through a sternotomy. So the point is that we're not reinventing the wheel, we're just doing it through a small hole. In conclusion, what I think I've demonstrated is that MiCS CABG is a safe operation, it's durable, it requires very little to get started as far as expenditures. You don't need a robot, you don't need any fancy television screens or any fancy equipment. It's very quick and easy to get started. It can be done in just about any hospital. We need to improve the diffusion. I think the training is a big problem. I think we don't really have a comprehensive way of training people, and I think Dr. DeBakey touched on that we don't really know how to train people at this point. The technology is improving continuously, which means that as the new inventions come on, this will be easier and easier, and our results will get more and more better. The acceptance by surgeons is also a big thing. Some of the more senior surgeons look at this as hogwash or baloney, but the reality is I think we all need to get on board with learning this technology, and I think I demonstrated why. But the one thing I will make a prediction, if you're not able to, at the very least, put a mammary onto the LED within the next 5 years, you're very slowly going to be squeezed out of the coronary business, because those cases will be going to surgeons who will be doing minimally invasive coronary bypass, or they'll be being done by the cardiologist. And that's it. Thank you for the time, and any questions I'll be happy to answer. Or do you have any questions at the end?